our state. And so to that end, we are doing a number of different things. We, of course, operate our accreditation process for folks to gain accreditation by us, thereby being able to have access and be listed on the state registry for recovery residences, as well as be able to be a referral source and be publicized as Waqrr accredited. That's a real value add to your residents. So if you're in that process already, congratulations. If you've already been accredited, that's great. And we know a number of folks are in that process. The second thing we do is professional development like this. So we try to stay in touch with what's going on around the state and pass along information to you all about the field, as well as really specific things that relate to recovery residences and how we operate and so on. And so this is probably one of the former, meaning we have with us someone from the Healthcare Authority, Jessica Blose. Jessica is the State Opioid Treatment Authority, and she'll tell you briefly about her role, but Jessica has offered to come and give us an update on what's going on statewide in her field, which is specifically around treatment for opioid disorder. And she's going to talk to us a bit about where we stand in terms of overdose and so on, which that crisis has been exacerbated by the present pandemic, of course. And so she has some fresh data for us. So really looking forward to that. So Jessica is going to talk to us for a while. There are a couple places in the middle where she's going to ask for some feedback. And at that point, when she does that, we'll ask you to just raise your hand. And to do that, there's a little participants button down there at the bottom of your Zoom screen, and you click on that, and then there's a little place on the bottom where you can do a hand raise, and then unmute yourself. And Justin, who is also with us, Justin, welcome. Justin is our coordinator, and he will be there to call on you and to unmute you if you forget how to do that. So we'll be interactive along the way, but most of the time we'll give Jessica the floor, and then afterward we'll update you on a couple things that Waqrr's up to in terms of our future events, and really looking forward to the schedule that we have ahead this the late winter and spring and going into the summer. So without any further ado, Jessica, thank you so much for joining us today, and really looking forward to hearing your update and what you have to say to us. So I'll turn it over to you.
Awesome. Hi everyone, I'm Jessica Blose. As mentioned, I work for Washington State Healthcare Authority, and at Healthcare Authority I have a couple of roles. One of my main roles is as our state's Opiate Treatment Authority, and that's really just a scary sounding title that means I work on all things opiate treatment at the state. And then also, I'm a manager of our behavioral health clinical support unit, so I help work on increasing the quality of care for all behavioral health. That could be mental health and SUD, not just things related to opioids. But just want to make sure if everyone's able to see my screen share before we get going.
Looks good.
Okay, awesome. Well, now without further ado, let's kind of jump into this. So today we're going to be actually talking about a couple of different things. One, I do want to give an update about how the COVID-19 pandemic is really impacting the opiate epidemic in our state. Some different recommendations, two specifically related to particularly medications for opiate use disorder that all recovery residences can consider to know about how they can help us to address the ongoing opiate epidemic. Different resources for recovery residences and way to reach out for one-on-one technical assistance that's available to you all for free from Healthcare Authority. And then again, just some background information about the general efficacy and how important it is to have information that's accurate about medications for opiate use disorder. So again, let's just start with, we're in this pandemic. COVID-19, unfortunately, is still going in full force, both in our state and nationwide. And let's have a, look at how it is potentially impacting us during this pandemic. So really, there's a lot of information here. I'm gonna kind of read these slides almost verbatim because this is new breaking news, and We've been seeing nationwide in the media lots of information saying other states have been seeing significant increases in drug overdoses right now and opiate overdoses during this pandemic. And it seems like we have finally started to get that data here in Washington as well. And unfortunately, rates of overdoses are appearing to be climbing in our state, both with opiate overdoses and then just drug overdoses in general. And we feel like this is information that should be helpful for you all to know about. So as it says in the first half of 2020, we know drug overdose deaths involving fentanyl have more than doubled compared to the first half of 2019. Overall, drug overdoses for this time period have also increased by 35%. So we've had 822 deaths. And then again, about a third of those drug overdose deaths did involve specifically fentanyl being in the drug supply. And that does include individuals who might have been using fentanyl straight up, individuals who were using opiates that were also had fentanyl cut into them. And it could also be individuals using other drugs that are not opioids, maybe like stimulants, methamphetamines, or cocaine that may also have had fentanyl in it. Again, fentanyl deaths has been increasing, like it says here, since 2015 by about 47%. And then totally outside of fentanyl, we also have started to see more, again, stimulant only related overdose deaths. Cocaine deaths, for example, have doubled in the first half of 2020 compared to the 2019 time period. Same thing with methamphetamines, increased by 23% in the first half of 2020, or I'm sorry, this first semester of 2020 versus that same time period in 2019. And again, highlighting the majority of the drug overdose deaths that we are seeing are multi-drug, meaning that it could be fentanyl in other types of drugs as well. It's not only just fentanyl, again, on its own. It could be fentanyl mixed into other opiates, fentanyl mixed into other stimulants, and then even 46% of all the cocaine deaths that we just talked about have included fentanyl as well. And again, we've been trying to look more at our state into things about disparity and trying to look to see if we see trends in different populations. We are seeing 70% of all the drug overdose deaths in this increase being among males, and particularly 74% for the fentanyl group. And again, we're seeing a median age of around 44 years of age for all drugs and 35 years of age for fentanyl. So really just showing the wide swath of our population this could be impacting. And then again, our Washington State Crime Lab, which reviews different types of substances that are found on the site of different overdoses and with police busts, we are seeing increased amounts of findings of fentanyl and fentanyl analogs within those findings. And then the last part that's pretty sobering is this is kind of breaking news out of King County. They actually have just started sending out a major media blitz on this, but they have identified through their King County Medical Examiner's Office that during the time period of December 27th to just January 19th, just a few weeks ago, there were 42 suspected or confirmed overdose deaths just in that 2-week time period alone in King County, which is the highest amount of overdose deaths that has ever been recorded in King County during a 2-week time period. So basically, we are really starting to see, again, a larger amount of overdose deaths. There could be a lot of reasons why that could be occurring, but the one thing we can say for sure is it does seem to be correlated with the increased amount of fentanyl that is getting into the local drug supply in Washington State. So I'm sharing all this information, again, very sobering facts. It can lead people to feeling very depressed and in a bad place, but also I think what we need to take from this, though, is that there are things that your recovery residents can do to help us combat the opiate epidemic and then these rise in overdose deaths that we're seeing in our state. So we're going to talk about 2 specific recommendations for you all to consider today, and that we'll do a little bit of a deeper dive in. So the first recommendation is really Recovery residences of all kinds should be reviewing their internal policy and procedures regarding residents taking MOUD. So I'm going to say MOUD. That's really just an acronym for medications to treat opiate use disorder. We're going to get more into what that means in just a second. But really, all recovery residences should be making sure you have policies and procedures in place that are not inadvertently stigmatizing or discriminating against residents who might be taking these medications. So you're probably thinking, why should we spend so much time on policies around if clients can take these medications? And the real reason why is really these medications to treat opiate use disorder are the most effective form of treatment for all opiate use disorder. And an important thing to remember is effective treatment is also effective overdose prevention. So let's talk about what we mean when we're saying MOUD. So these are the names of the medications that fall into this category. Methadone is one. Buprenorphine, or otherwise known as like Suboxone or Subutex, is another. And then naltrexone, or otherwise known as Vivitrol. And again, we're going to spend a couple minutes just talking about these medications and how effective they actually are, because I think it's important to know as we think about why we want to make sure the policies at recovery residences are inclusive and allowing residents to continue to take these medications. So you can see here across the screen, there's a couple different categories, but if you look to this box that's in the middle, these medications are so effective that actually, if you are someone who's taking methadone products or buprenorphine products, you have lowered your risk of overdose by about 50%. Now, there is almost no medication on the market that has this type of profound impact. If you were someone who's taking medications for hypertension or medications to lower your cholesterol, or even medications for different psychiatric disorders, there's almost nothing you can take that will lower your risk of having certain complications by 50%. Something that's not on the screen, but I would also like to talk about is, again, in any given area, including in Washington State, you can estimate up to 1% to 2% of the overall population may have an opiate use disorder. Of course, you all know as recovery residence providers, a huge amount of your individuals who might be staying in your residences may be someone who has opiate use disorder as a diagnosis, or even polysubstance use that is inclusive of opiate use disorder. As we all know, anytime someone takes an opiate, that could be the time that that person overdoses, especially knowing that there is more fentanyl in the drug supply. So one of the best ways to reduce the risk of someone experiencing withdrawal symptomology, so symptoms from withdrawal, and to reduce cravings, is for someone to be on these medications. And actually, in addition to just reducing the overdose death risk, someone who's on one of these medications, methadone or buprenorphine specifically, will actually, you are almost 5 times more likely to get to 5 years of recovery. And that meaning, a 5-year time period without any major relapses. If you take these medications, you are 5 times more likely to get to that than if you are taking no medications at all. So again, it's important to talk when we're discussing statistics. These are numbers. Of course, they're not inclusive of everybody. There may be some individuals who are able to have a lot of success without taking these medications, and that's great. But really, all the evidence shows that for the greatest majority of people, you are, again, really more likely to have success if you're taking these medications. And we're going to be focusing today's discussion mainly on methadone and buprenorphine products, and not as much on naltrexone, because naltrexone in our state is largely available in an injectable form. So with an injectable form, someone will go see their doctor and get this medication injected into their body. And there really isn't anything that the individual going into a recovery residence would need to do with this injectable form to store medications and know how to keep it held safely. So there's really not a lot of policy and procedures your agencies would need to have around naltrexone versus methadone and buprenorphine or oral medications taken orally, usually or sublingually under the tongue, and therefore your agency would likely need to have different policies and procedures in place. But again, why does the state promote so much medications for opiate use disorder? Again, it's considered evidence-based treatment. It is actually the only form of evidence-based treatment supported for opiate use disorder specifically. Um, Another thing too, just because someone is taking these medications, we're not saying it replaces other forms of treatment. We all know, again, it can be extremely beneficial for helping withdrawal symptomology and craving symptoms. But if someone has had a lot of trauma in their life, um, from things like a bad childhood, abusive relationships, and then different things that can help someone gain recovery, you know, learning better to connect with folks, creating a new sober recovery network, those types of things would still and could still be supported through the use of counseling, through self-help groups, and then other safe and sober activities. So again, this isn't replacing other forms of treatment. It's just one thing that could be in the client's toolkit that will help them to have overall success. We also promote this because it really allows for patient choice. Just like with any medication, there should be actually shared decision making between a medical prescriber and that client to talk about which medication might be most effective for them. So, for these patients, again, just like if someone was going to be prescribed medication for depression, some medications work better for some folks, some other medications work better for other folks. Some folks will be able to deal with their depression with no medication. Some people might be on a medication long term, some might be on a medication short term. Really should be individualized. And that's really what we want to promote with these medications. It really should be an individualized, patient driven choice. It helps to support healthcare integration at work. What we mean by this is our whole healthcare field is kind of hurtling towards trying to bring behavioral health and physical health services together. So, really, again, offering medications as an additional intervention to treat someone with a substance use disorder, in addition to psychosocial counseling services and then recovery support services, things like that. It really brings a whole person perspective to trying to treat someone and again give them the best chance at success. And as we all know, substance use disorder is a chronic relapsing brain disease. And based on this medical model of the brain disease for substance use disorder, having medications again be one part of that toolkit for a patient to help impact their brain really again offers one of the biggest opportunities for folks to have success. And then the last part we'll talk about before we get back to more recovery residences is again, there's lots of myths around medications for opiate use disorder. One of them is that, again, these medications are just trading one substance for another. Again, that is not accurate. These medications are considered medications, again, similar to medications that would be prescribed for mental health conditions, and that's how they should be thought of. There's a misnomer that these medications are only meant for short term. That is actually, again, not accurate. Now that a lot of these medications have been out for long periods of time and we've been able to study them for decades, these medications have shown that the longer you are on them, you're actually more likely to have better results. And then also, there is no evidence to show that there's any benefit of a person stopping the taking of these medications if that's what's medically necessary for them. Again, I want to make that clear. There is no evidence to show that someone who's on a medication for just a year or two and then stops has any better outcomes than someone who's on these medications long term. And oftentimes, folks who are on these medications long term are the ones who are having the best outcomes. You might be wondering, is the individual's condition severe enough that they even need these medications? So again, it's a variety of medication types that can be tailored to the client's individual needs. And with that, there are different medications and different medication amounts that can be used to treat mild, moderate, and severe opiate use disorder. And there's sometimes a misnomer that taking these medications will actually increase the risk of overdose in the patients. As we talked about earlier, that is absolutely not true. It actually is likely to decrease your overdose risk by 50% for methadone and buprenorphine. And again, individuals who do not take any medications do not have these types of decreases in overdose risk. And then questions about, is providing this medication going to disrupt and hinder someone's recovery process? So there is, again, no evidence to show that. Again, it's just one part of someone's toolkit to help them in their overall recovery. And then again, sometimes people say, well, there isn't really any proof that these medications are better than abstinence-based treatment. And again, that is actually not true. The only form of evidence-based treatment that current research supports for opiate use disorder are these medications. They all should be considered as a first-line approach to treatment. And this is information that's supported by groups like the American Academy of Addiction Psychiatry, the American Medical Association, the National Institute on Drug Abuse, the Substance Use and Mental Health Services Administration, NIDA, the CDC, our state, Washington State. So pretty much every major government and research entity out there is in complete alignment that, again, these medications are considered evidence-based treatment. So now, though, we're going to start talking about, again, how this actually pertains to recovery residences. But before we do, I do want to take a quick discussion break to ask you all, and I'm really genuinely interested in feedback so we can know what types of technical assistance material that we can develop in the future on this topic. But I want to know from everyone who's on the call today, what do you think are some of the most common concerns that a recovery residents might have? And this could be, the administrative providers, the staff, or even residents there. What do you think are the most common concerns that a recovery residents and everyone who works with it might have about having a client who's taking methadone or buprenorphine products coming on site to the recovery residence? So I think we're going to pause, and I believe you can raise your hand through this, and that Justin or Alan will call on different people if you have comments.
So it looks like Kristen has.
Kristen, yes. Sorry, I don't know how to turn on my video. So I think maybe concern of misuse, and how to help residents manage their medication and the behaviors from the medication. I also believe that having a recovery residence where some are home, where some are taking MOUD and some are not, and if that can cause separation and disruption of unity in the house. And that's all I have.
Thank you.
Thank you.
I'll throw in a couple that I hear pretty regularly, and I really want others to participate as well. But I hear, and early on, this is from our own experience as well, being honest, that the common belief is that people who are on medications are triggering other people who aren't. So because some of the behavior kind of looks the same. So nodding off in meetings and conversations, and a certain look in people's eyes, those kinds of things, for people who have been opiate users, that those things can feel triggering to them. That's a fairly common thing that we hear from residents as well as operators who have sort of seen that at play.
Awesome. I'm taking down a couple notes to see if we can touch on some of these things through the call. Does anyone else have any other thoughts or things that you've heard? Again, it could be from staff, could be at the administrative level, can be from residents themselves. What are the concerns that folks have had most often, or that you've had to already deal with in your recovery residence?
Yeah, really open to other feedback. I've got more because I've thought about this quite a bit over the years, but would love to hear from the rest of you. Just things that you've heard or things that you're thinking yourself. What's the big impediment in your own story or in your own the story of your organization or houses that have maybe kept you from moving in this direction or maybe did at one point? I think one thing that I hear is that Suboxone has tradable value. There's monetary value, street value. So residents selling Suboxone. We just had a case this week of a resident who was looking to buy Suboxone from other residents in their house. So just I would put sort of the overall category of logistics. So how do you work with residents it's a challenge to sort of help them kind of abide by the dosage that they're supposed to be taking, and if they don't feel like they're taking the right dosage, what's the best kind of intervention to help them kind of get to that place so that they're not resorting to what we call old behavior, which is buying and selling a controlled substance in their house. So how do we help them navigate that, especially in homes where there aren't staffed? So maybe there's a house assistant or a house manager, and that's kind of all you have on site. And that person feels like, well, it's a little bit outside of my pay grade to be helping people manage their medication, and it's starting to look like there's drugs being bought and sold in the house. So there's this kind of what I'd call in general just a management issue that needs to be discussed in terms of what this actually looks like on the ground.
Definitely. Well, that's really helpful. So let's, I guess at this point, unless there's any other comments from the group, we'll just continue on, and I'm going to try and touch on some of these items throughout the presentation. Any other comments at all? Or...
Nope, I think we can move on. Thanks, Jessica.
Thanks. So I think something that's really, really important for everyone to know, basically as a recovery resident, is, again, we're going to touch upon some of these issues and how you can request technical assistance from us at the state to get one-on-one free technical assistance and how to resolve some of the topics we just talked about. But it's really, really important to know why each recovery resident should actually take a deep look at your own internal policy and procedures around this topic. So basically, both in our state and then nationwide, we're all familiar with terms of discrimination and things like the ADA. We may be less familiar with things like WLAD, which is the Washington Law Against Discrimination. But essentially, both WLAD and then also the ADA talk about how discrimination against people with a disability is considered unlawful. Well, both the state and the federal government do consider substance use disorder to be a condition that could result in impairment to daily life. And therefore, technically, in the eyes of the law, disability does uncover anyone with a substance use disorder. So by proxy with that, if there's ever anything that might be in a policy or procedure for anywhere that excludes an individual who's taking one of these medications from opportunities related to healthcare, housing, which would include recovery residences and shelters, employment, or other things, that could all inadvertently be considered discriminatory behavior. So if there's any refusal or limits that get put on an individual that reflects their inability to access programs, jobs, housing, or other services that are considered protected activities, just because they're taking a medication for opiate use disorder that's prescribed to them, you could accidentally be violating both state and federal law. Similarly, if you have policy and procedures in place that might actually prohibit or require someone to stop taking their medication or to change the amount of medication they've been prescribed to take as a condition of you accepting them into that protected activity, again, that could be something that might hypothetically be considered discriminatory behavior. And then again, this is just reiterating our current state and federal law does protect individuals who are taking these medications. whether it's medication for the treatment of a mental health condition or for the treatment of a substance use disorder condition, including these opiate medications. It does protect them against discrimination in settings like recovery residences. And again, if you may have policies currently in place that say something like, we can't accept a client on methadone at this time, or we will accept someone on buprenorphine, but if you happen to be taking above, I don't know, like 8 milligrams or something, we can't accept you. Policies like that are just flat on its face, one way or another, we can't take you, do technically probably fall into a discriminatory category and could be something that'd be really helpful for you all to know about, because it puts you at legal risk of inadvertently being discriminating as recovery residences. So again, this is kind of reiterating the points we just were talking about. If a recovery residence were to refuse an individual just because they're taking these medications, you could again be violating them. So again, let's talk about specifically the laws a little bit more. The ADA does specifically prohibit most recovery residences from removing an individual from a recovery residence, from refusing to accept an individual to a recovery residence, or again, discriminating in terms and conditions against someone on the basis of the fact that they have this disability. You might be wondering, well, how do we know if the ADA will pertain to us? Basically, any private service provider that offers a recovery residence care, and then also if you accept any money that comes from federal government in any way through federal grants, contracts, or aid, you have to comply with all of these, as well as any other non-discrimination requirements noted in the Rehabilitation Act, which is another law you might want to look up. And then again, we have the state-specific version of basically the ADA in our state. It's called WALAD. And again, in that instance as well, if a recovery residence ever were to refuse or limit a person from accessing a recovery residence just because they're taking one of these medications, you could inadvertently be violating WALAD. And again, you might be thinking, gosh, Jessica's just beating this back like a dead horse. Why there's so many slides on the same thing? But again, I think it's really important to know, because you are all doing such important, amazing work. And again, our recovery residences are such an important and necessary part of our recovery support system environment, that we don't want anyone to accidentally get into any types of legal trouble for policies and procedures they have that maybe they just haven't updated them in a really long time. So we want to make it very clear that the law's interpretation of this is clear, and what you will have to do is make sure you don't have policy and procedures that, again, flat on their face, require people to either stop taking medication to enter, or just says, hey, we can't take you. But instead, you would want to spend time building policy and procedures on some of the things that were brought up in the comment section that we just talked about, such as, well, how are we going to maybe inventory and store these medications in a safe way? How can we set up policy and procedures around what we would do if diversion is occurring? And then again, if someone appears to be having a negative effect like over sedation, aka nodding out from these medications, how will we deal with those types of scenarios and get the patient the help they need to have their medications adjusted by their medical provider? Again, making it very clear, all these discrimination laws, who has to also comply with them? Really, any businesses that are open to the public, including different types of healthcare providers, places that might employ more than 8 or more individuals, most housing providers, public agencies like court systems, local government like zoning and land use, and then a lot of other places. And then another thing to think about is there's this concept called reasonable accommodations. And you might be familiar with that from employer-based things, like if an employee needs a reasonable accommodation. But really, in this sense, a business, an employer, a housing provider, a recovery residence, really, you would have to provide a reasonable accommodation So an example of this would be you have patients who maybe are taking medications to treat a chronic health condition. Diabetes medications, you might be having someone taking a medication to treat psychiatric conditions. You might have, again, accommodations you're making for individuals who are pregnant or parenting. If you have accommodations built into your policy and procedures for all these other types of examples, but you don't have accommodations to talk about how to store medications and things like that for opiate use disorder, that could be another example of potential liability if you're not actually providing a reasonable accommodation to individuals on the opiate medications specifically. So now we're going to say what to do with this. Again, first step, review your policy and procedures, see if you have anything in place that you might need to change, and work internally to start thinking about, okay, how can we change these things and what types of new policies do we need to introduce? You might be looking for more information on this. So we have a couple different pages of links here. This PowerPoint presentation is going to be sent out to everyone. So you can check out all of these different resources. This is also information that you could share if you have different like legal staff or leadership that you're working with at your recovery residence, if you want to look more into the topics specifically related to discrimination and civil rights that we were just talking about. But we can take a couple minutes at this part. Also, again, at this point, again, there's lots of questions you're probably thinking. You might be thinking, like, well, what, again, medications, might a client need to bring into our residences? Again, how can we offer safe storage and inventory of these medications on site? Are there state rules about this saying like what we are allowed to hold, or if we have to have special things, like do we have to lock things up? Do we have to put them in a lockbox? Can we put them in a locking bag? Do we have to have a safe? Should we be treating methadone and buprenorphine products differently from each other? What do we do with mental health medications? Should we have the exact same policies for all medications? What do we do if there's diversion? How do we have discussions about this with other, I guess, members in the House? So again, there's lots and lots of questions that are probably coming up. And we've actually talked about maybe me coming back in the future and doing a more thorough presentation on some of these types of topics. But in the interim, basically, we're here to offer our services. Healthcare Authority and my work group of Healthcare Authority, working on all things opiate treatment. We want to help providers all across the state to have real thorough one-on-one free technical assistance for your recovery residents to talk about all of these topics. So my contact information is here. All you have to do is either call or email me. Identify which recovery residents you're with. Give me some dates and times that you feel like you would be open to meeting. And again, we at Healthcare Authority want to be partners in helping you to create policy and procedures. Because as we know, there aren't really a lot of state rules at this time that make it very clear for you all to know what are some of the best things to do. And really, policy and procedures need to be tailored and individualized to the needs of your recovery residents. I know, as Alan mentioned, staffing might look different from recovery residents to recovery residents. So at some recovery residences, there may be certain like house managers who might be available to help with certain things, versus others, it might be more like a peer-led place. And again, it's hard to come up with one size fits all feedback for these presentations, but we really would be very, very interested in helping anyone that has a question on this topic to offer, again, one-on-one technical assistance. And as we offer this more technical assistance, we can start to see where are there common themes. And without getting this type of feedback and having this dialogue with the important providers like yourself, that will really help us to also create maybe a toolkit that we could potentially put out at some point this year that will have certain sections on these different topics. And maybe we can give some universal guidance that at this point, we're still just not sure about what is the best guidance to give out, because this is, again, such a new topic. And we want to know what is the information that would be of most help to you all. And I'm going to pause for a second. I see that there's like a question in the chat box. I don't know but if someone could read it, to see if it's something we should address right now.
Yeah, so the question says, let's see, is it appropriate for a recovery house to expect its residents to share with fellow residents that they are using MOUD? That's by Shannon.
Well, I guess going back to a concept related to reasonable, like accommodations, I guess thinking about what is your existing policy and procedure. Is there an expectation that a resident in a home shares their personal health information about if they're taking a psych med? Like if someone's on an antipsychotic or a SSRI, is that something that would be necessarily like required in a policy that they share? Another question would be, I definitely think though, if a client wants to self-report what they are taking, or again, everyone's living together. So, you know, if someone has, if either the residence maintains all of the medications in a secure location, that is one thing like your residents could do. You can offer a safe space that is lockable, where someone can actually keep their medications again securely stored every day in the residence. But if someone's going to get this medication every day, you know, realistically, people in the same house are going to know what people are doing. Everyone's going to know everyone's business. There could be definitely discussions that can take place about how to normalize certain things. I mean, there's a big difference between, I know we used a worst case example scenario before about someone being over sedated, but if someone is on a stable therapeutic dose of these medications, there should actually be no sedation. If someone is sedated, it's happening because of two reasons. One, the person's medication needs to be further adjusted. And if anyone was taking any medication and having a negative complication, we would probably tell them things like, hey, I think you really need to go get an appointment with your doctor to get checked out because you've been taking this medicine and it seems like, you know, things aren't right with you. And then the other thing, of course, could always be a chance if that person might be using another substance that's interacting with the medication. But again, that's a worst case scenario. Most folks, again, on a stable therapeutic dose of methadone or buprenorphine, you should not know physically that they are on these medications. But in those instances, it can be helpful for the house staff to have different policy and procedures about how to have discussions and to normalize the concept. Again, some folks will take medications as part of their treatment and some folks will not. So there are lots of different ways you can address that, and we can get into more detail on some of these questions, but these are also the types of conversations that we can have at greater length if you do reach out and request that one-on-one technical assistance from us. And it seemed like maybe there's another question potentially.
No, I just hadn't
Okay.
officially marked it off as answered because I was waiting until the end.
But I mean, this is really good conversation. And again, I think this will help us, a healthcare authority, to develop better materials that will be really useful for you all on different conversations to have, and then ideas for different types of policies.
Looks like Shannon responded saying, thank you, Jessica. Looking forward to connecting with you and our agency.
Cool. Yeah, I'm looking forward to connecting with you guys too. So taking another discussion break, and maybe we've already started to answer some of these things, but again, just what are some of the biggest barriers you think of now after we've had a couple of these slides, thinking about what your organization might need to change in its policies to allow individuals to bring MOUD medications on site? Where do you think there maybe is a need for some policy topics that might be missing from your policies? And Also, is anyone who's on the call right now had any experience with having to create new policy and procedures for your recovery residents already on these topics? And if you want to share any like experiences or lessons learned that you've had by having to address some of these topics and questions already at your sites. Or are these
So,
things that are already coming up internally?
oh, someone else, go ahead. I'll speak for our organization up here in Skagit County. We have been working on these things for, boy, I'm trying to remember now, it's probably 3 or 4 years now. I always lose track of years. They just seem to go faster these days. But anyway, one thing that we do is we really try to communicate richly, obviously with our residents who are taking medications, but also on occasion even with their providers. So we ask them to fill out releases of information with their providers, so that we really believe in, and providers in our area, generally speaking, see this as a team approach, which, as you mentioned earlier, Jessica, was super helpful, to think of the medication as one tool in the toolbox. And we provide a lot of the other tools in the toolbox. And so if we as part of a person's team are communicating primarily with the resident, but every once in a while kind of in a more team kind of approach, we can really work toward the benefits, really for the benefit of each resident. So we found that to be really helpful. And there are just a lot of those sort of on the ground things that, especially at the beginning, we had to wrestle with. And what we found is once we sort of got over those hurdles, and I think generally stigma in the recovery community has really decreased around medications. Still there in some places for sure, but we find that our other residents are just a lot less, it's not a topic of conversation nearly as much now as it used to be for them. And I think that's just because we're not treating it as a big deal, unless something comes up, in which case we really try to work with residents on their behaviors as opposed to kind of trying to diagnose the reason for the behavior. So I notice you're falling asleep in the meeting a lot lately. What do you think might be going on? So as opposed to making an assumption that it's about their medication, let's talk about what it could be. And then basically putting it back on the resident to say, really, it is your responsibility to be fully present in these things. So if you think there's something going on with your medication, would strongly encourage you to deal with that. We're on your side. Anything we can do to support and help you, or if there's some other sleep thing going on or whatever, we really want to be helpful. So really kind of walking alongside the person to help them be the kind of the owner of their process has been really helpful for us.
Well, I also really appreciate you bringing up just the importance of maybe having a policy to have releases so you can talk with providers, because I know one of the concerns that got brought up was diversion. Again, if there is genuine diversion or, substance use happening on site in the house, you could still have policies that say, certain things are unacceptable in the residence environment. And again, if you're treating things the same across the board, that's not an example of some type of a discrimination. But also, the healthcare provider that's prescribing that medication would probably really want to hear if that person is truly struggling or diverting or selling portions of their medication. So in that way, they can work with that individual to say, we want you to still take these medications to have the access and the benefit and the overall reduction of overdose risk and your management of withdrawal and craving symptoms. But maybe we're not going to give you take-home medications because we are worried about you diverting them. So you're going to have to physically come on site, or we're only going to give you a couple days worth at a time because we're worried about that. And they may not know as a healthcare provider that that's happening.
Of course.
They hear from you all at the residences. So going back to that team approach, it really you know, there's that expression, it takes a village, but someone in recovery really needs a whole community of support. And I think recovery residences and treatment providers can be really good partners to help folks. But again, we're not also saying that, again, if someone is on one of these medications and they're truly, you know, again, truly having diversion related issues, if your normal policy for all other substances and other things would be to say, you know, we have a series of negative actions and we may even ask you to leave, as long as you have, again, similar policies for different instances, you can still, yeah, you don't have to necessarily keep someone on site if they are a risk to the whole safety of the house. Or sorry, the recovery residence.
Yeah.
Any other quick thoughts before we get on to our last recommendation for recovery residences? So the next recommendation is probably something a lot of you are already doing. All recovery residences right now, especially because of the rise in overdose risk, should really have naloxone on site and available, ready to go, and individuals in the recovery residence should know where it is, how to access it, and how to use it. So there is tons of information out there. I have been told by Alan and Justin that usually a lot of recovery residences, you might be eligible already for free naloxone through different state grant funded things, but also we all know grants aren't always forever, but there's actually other places you can get naloxone. Staff from your recovery residence can use this one link through University of Washington's Alcohol and Drug Institute. They have this amazing website called stopoverdose.org. Has information on everything you could think of, as videos on how to use naloxone, whether it's the nasal form or the injectable form. They also have a really cool map feature, which is almost like a Google Maps type feature, and you can type in where your recovery residence is, and it will tell you all the pharmacies and places close by that will have access to naloxone. You can do things like send your staff to the local syringe exchange program. So you might think, okay, these programs are giving out syringes. What does this have to do with us? They also are able to give out free naloxone to anyone in that community. So you could potentially reach out to this syringe exchange program, send a staff member or someone there, and tell them you're in a recovery residence and you need more naloxone for your household. And they'll likely just hand it over to you for free. There's also county health departments sometimes that have naloxone. You could reach out to the health department and ask for free naloxone. Also, if you have any partnerships with any local healthcare providers, of course, you can always get a prescription written, which wouldn't necessarily pertain though for recovery residents. But there's this really cool thing right now. Our state does have a statewide standing order where anyone can actually go into a pharmacy and purchase naloxone. So maybe part of your policy and procedures would be, with all of the, you know, revenue that we raise to, you know, pay for the rent and to run the house, we want to make sure we allocate, I don't know, $50, $100 a year, whatever, to maintaining naloxone in the house. And then you would just be able to walk into a pharmacy that you can find through this Stop Overdose website, and you just walk up and you don't need to use insurance, and you can ask for naloxone. Also, the residents themselves, if they have insurance or Medicaid, Medicaid actually will pay for them to have naloxone. So as part of that, it will lose their benefits. So that could be something you can also think of as part of your policy and procedures. Maybe if you're thinking we're going to have to change our procedures to allow people to come on site with these medications for opiate use disorder, you could also say, you know, as part of that, we would want for you to also have naloxone on site. And they could use their own insurance benefits then to get naloxone and bring it on site. But again, it could be helpful to just have in the house in general, because again, we don't want anyone to be relapsing, but you know, realistically, relapses can and do happen, and it's very important again that this medication be available on site, and that there is, again, people know where it is, easily accessible. It's not necessarily in a place that's going to be like locked up and it's going to take, running down the hall and trying to find someone to come and unlock something, because every second counts. And then even thinking as part of like a group meeting one day, should, once a quarter, twice a year, should everyone in the house just, hang out and maybe watch one of these videos to make sure everyone knows how to use it. And then even if it's not happening in the residents themselves, this information might be able to share them if they're still, hopefully they're making different types of relationships, but realistically too, sometimes people still have, social relationships with people in their lives who may still also be using. So maybe this information can have a bigger ripple effect and can help others even outside of the recovery residents. And then again, we have some tips. If individuals want to use their own benefits, and as well as if the recovery residents wants to look into it, you can always call pharmacy to ask about, do you have this on stock? What is the cost going to be? What insurance covers it? So whether the residence is purchasing the naloxone for themselves or the individual uses their own benefits, you can have more information before you actually go to the pharmacy. And then again, there is no copay or limits under Medicaid. Private insurance can vary, but it usually covers. And again, lots of other interesting resources. And I guess that's one of the things I wanted to ask this group. And I see we also have a question. Well, what do you consider to be the biggest barriers to your organization being able to keep naloxone on site? Is it strictly just being at the whims of a grant and whether you're going to get the free grant funded naloxone? Is it a financial barrier? Is it that we have naloxone, but maybe folks don't really potentially know how to use it? I'm just curious to know any feedback that you all might have on this. And also I'll let Justin raise the question that's in the box.
All right, Shannon said, adult drug court's best practices standards has loads of supportive evidence explanations for the value and need for MOUD, a primary element in DC, Texas, and DC housing, as well as in custody, a very compelling case for the necessity of MOUD, as well as the need to make naloxone available in all of our offices. Provide it to all of our housing partners or treatment centers, including training for staff and residents.
Thank you for those comments. Very true. And since you mentioned like therapeutic courts, a lot of these topics that we're talking about, we are actually talking about in a huge variety of other settings as well. We're not just focusing on recovery residences alone. In the last couple of years, we've done tons of work to have similar discussions also with places like residential substance use disorder behavioral health agencies, therapeutic treatment courts, and really courts of all kinds to make sure they're allowing clients on methadone and buprenorphine. So we're talking skilled nursing facilities, aging and long-term care facilities, shelters in our state, mental health inpatient settings. Really, again, this whole conversation, it really, unfortunately, has taken the full scope of the opiate epidemic, getting to such a bad point where it's really risen this topic for all of us to be discussing it. But again, I'm just really thankful to have this time with you guys all here today to discuss these things so we can make things better for everyone. And I don't know, Alan, if you or anyone else have any other thoughts about maybe what could be some barriers specific to naloxone in the houses or residences.
Also, I might have just auto-filled in the where it says DC and TX. My brain naturally went to states and all that. I'm pretty sure that was supposed to be district court and treatment.
Yeah.
So I want to put that in if people want to read it
Right.
with that lens in the Q&A section. My apologies.
I think I'd be interested to hear if anyone has had trouble getting naloxone. I would be surprised. I think it's been pretty readily available, and the folks at the UW have done a great job of providing it to any of our providers who've asked. So boy, just like Jessica said, if you're having trouble or you can't find a source, please, please, please reach out to us, or when we send the PowerPoint, those links are going to be there. So you can just go right to the links and go find it. It should be very easy to find these days anyway, especially, and again, even through pharmacies indefinitely, you should be able to get it. So.
So really,
I ran into, just to mention, Jessica, I ran into a couple years ago when we first were making it available and making sure people had it. If you are accredited by Waqrr, you're required to have an naloxone kit in each home. So, and you're required to have staff and residents trained in how to use it. So all of our folks are, you know, we affirm and confirm that they have it upon their accreditation. That happens annually. But for the rest, it's not that hard to get. I ran into a couple years ago some folks who kind of were confusing naloxone with other medications, and they had sort of some principled stances against MOUDs, and those are ongoing conversations with those folks. But we were able to sort of clarify that naloxone is a first aid supply. Like, it's something you would have in your first aid kit that is well stocked. It just makes sense that you would have it on site. And so we had to just clear up a few misconceptions around what naloxone is. Naloxone isn't in the same category as the other medications that we've been talking about today. It really is a first aid necessity for anybody who works in the recovery world. And so hopefully, I'm assuming this group is savvy enough to know that it's just something that it's like Band-Aids and gauze. You need to have it. And we've not run into really much resistance. Folks have been really on board and have been looking for ways to get it. So always happy to help with that.
definitely. And I think, again, thank you for letting me know. And I'm so glad to hear that all of these sites likely probably already have naloxone on hand and have been training staff and other folks in the houses how to use it. But again, I just think, going back to the first couple slides, we discussed the overdose epidemic and the fentanyl proliferation in our state drug supply is on the rise. It's such an important thing. This is also information that may be helpful to share with residents. Again, we know that like a scared straight approach, of course, is not what necessarily helps people with recovery. But again, with sometimes with drug use or opiate use, you know, that one use, that one relapse can be the thing that actually kills you, especially if you've, not been using for a long period of time and your tolerance has dropped to different things. So going back to just the importance of doing all the amazing work that you guys are already doing to offer a safe and supportive environment for individuals, because, I was listening to someone talk recently about a drug overdose that was experienced by their relative, and they made a comment about, yes, it was the drug that killed them, but I really feel like it was the stigma that killed them, because they were struggling and they didn't feel comfortable to like reach out and ask for help. They didn't feel like they could say, I'm struggling, or maybe I need to try something different, or, try different treatment. And they said, I think it's the stigma that killed my brother. And that was really profound to me, because again, we are here to help support people in their recovery. And again, the best way to do that is to have a safe, supportive, and non-stigmatizing environment to try and help people get the help and support that they need so they have the best chance at being in recovery. And I hope that, again, by looking at your policy and procedures on these things, here are 2 concrete things you can do and these areas that will help, again, doing the great work that you guys are already doing to offer that safe and supportive environment. And we are here to help. So please feel free to reach out. Sincerely, we love doing one-on-one technical assistance calls. It's one of the biggest things my work group does. And again, the more feedback we get from you all, it will actually help us to create better products for everyone in the future. So that will pretty much conclude my formal presentation. And I don't know if anyone has any other thoughts or things they want to talk about. And then I'll let Alan and Justin, lead the rest of the discussion before we wrap up.
Anything else? All right, I'm just going to talk for a minute in the way of wrap up. And so if you want to interject with anything else, please do. And Justin will let us know. We want to be sure that you get any questions answered, or if you have input for the topics, I would love to hear that. So as I mentioned, this is part of a series. And so please stay tuned to our website. If you go to waqrr.org/events, that's where you'll find a list of what we're up to. We have a couple things coming up. Our webinar series continues in February. We have one webinar on return to use policies. And so we have colleagues from Ohio. Ohio Recovery Housing is really just a flagship organization that has been doing certification of Ohio homes for many years, and they just have really done great work. And a colleague of mine has offered to come and lead that. Actually, two colleagues are coming from Ohio. The great thing about the pandemic, I suppose, is this opportunity to have people from around the country join us just like they were here. So anyway, they will be talking about return to use policies and so many ins and outs of return to use policies around, what does it make sense to remove somebody, and that being a very serious thing. And so what kind of things do we think about in terms of when we do that, how long somebody should stay away, if they stay away at all, what kind of things need to be talked about in regards to welcoming them back, and how do you create a safe environment for people. There's incentives and disincentives, a lot of good things. So we wrote a little blurb on the website that sort of asks some of those questions and more that you can look at and get a sense and bring your own, of course. It's a really tricky subject and really worthwhile spending some time on. So that's our next webinar. Also on February 5th, we have an event for people who, still online, of course, for people who want to join our accreditation teams. So if you want to learn how to be one of the folks who is a part of accrediting recovery residences in the state, then we're doing kind of an all-day Zoom session on that. And so you can register for that. But essentially, there are 3 components to our process, which I won't walk through right now, but we need volunteers in each of those components. So whether you are an operator yourself or you're just a stakeholder, somebody who's just really interested in being sure that accreditation is meaningful and that homes really get a good look as they step into that process, we'd love to have you join that. So that's on the 5th of February, and you can again register and read more about that on our website. And then you'll also be able to see what's coming up. We're really excited about some of the webinars we have coming. We have an all-day kind of recovery housing 101 event that we're doing a couple times in the next few months as well. And that's just for folks who are just kind of new to the field. Maybe you know somebody who's kind of wants to get started in opening a residence and just wants to know what that's about and how it all works, and a lot of good open table discussions around all kinds of policy issues and so on. So that's a really good event as well. And then we'll be also talking, we have another separate event around licensing and Medicaid reimbursement. So if you're a provider and you want to take the next step into maybe doing something that you could get reimbursed for by Medicaid, that is a whole other kind of set of policies, state guidelines, and there's a lot involved in doing that. But some folks have been operating a while and are ready to take that step. So we have a session coming up on that as well. So a packed spring and going into early summer. We're programmed out now through June, and so take a look at those, and would love to have you join us for any of those. Jessica, any final words or thoughts from you?
Not really. Again, I'm so thankful for this opportunity to connect with you all as recovery residences. I mean, you all know, one of the #1 needs of folks is a safe place to stay, especially right now with the pandemic, knowing so many people also are struggling financially. Again, having you all as an important part of our recovery support network. Yeah, we're just so thankful for all the work you're doing. And I agree. It sounds like there's lots of information about also how you can tap into becoming a Medicaid type provider and getting resources from us at the state. So if you're not already doing that, please consider because we'd love to have you as more a part of our official network in that sense. And also please feel free to reach out, like I said, at any point if you have any questions about anything related to opioids.
Great. Justin, anything else in the chat or anything else that you'd like to add?
There's nothing else in the chat, and I think we've got all of our bases covered on that. So,
all right. Well, thank you all for joining us. And for those who are joining, watching the recorded version of this, again, all of that same information still applies. You can feel free to reach out, and look forward to being in touch. And Justin will coordinate getting the PowerPoint sent out to everybody in the next few days, along with an evaluation, which we highly value your input on these sessions as well. So, and we'll make sure Jessica gets that information too. So thanks all, take care, have a great Thursday, Friday, and weekend coming up, and we'll see you next time.